Welcome to the West of Berkshire Safeguarding Adults Board brief guide for professionals on unconscious bias. So what is unconscious bias? Unconscious bias refers to the automatic judgments and stereotypes that we form about others. Unconscious bias is a positive or negative mental attitude that we use to determine how we view and interact with people, either individually, as a group, or as a community. Our biases are shaped by our upbringing, our personal life experiences, and where we live, our culture and cultural influences, and media, and even the culture and expectations of where we work and who we work with. In health and social care, this can influence how we engage and communicate with the people that we come into contact with, including how we help and support them, how we assess any needs or risks, and how we interpret behaviour or anticipate outcomes. So, unconscious bias matters in health and social care. Health and social care professionals are entrusted with working with and alongside people, providing a service to people, often supporting vulnerable individuals and having to advocate for them. Unconscious bias can affect how we communicate with people. It can skew our assessments and interventions, and it can affect how we interpret the needs of the people that we support. It can reinforce systemic inequalities, and it can affect or undermine trust and rapport building. Well-intentioned professionals can unintentionally perpetuate harm if biases go unchecked. So let's have a look at some common biases that we might see in our practice. Confirmation bias. This is when we look for information and evidence that supports our initial opinion or impression of a person or a situation. For example, it could be assuming that someone's fatigue is due to depression without supporting them to seek further medical testing and exploration of possible physical causes like anemia or thyroid issues. It could be as a social care professional that you're convinced that an adult is safe in their current environment, and that you may then unconsciously ignore or minimise new concerns that are raised by family or carers that suggest otherwise. Racial or ethnic bias. Racial bias refers to the preconceived notions, attitudes or actions that unconsciously impact our behaviour, that are influenced by an individual's race, leading to unfair treatment or discrimination, over or underestimating risk based on race or ethnicity. For example, professionals not taking concerns about adults from Black, Asian and minoritised ethnic communities as seriously as they might do from adults from other communities. Professionals might dismiss certain behaviours or practices as being from part of that community, their culture, and as a result not take the necessary action to protect that person. Cultural bias. Interpreting behaviours or situations from your own cultural perspective due to familiarity or unfamiliarity with cultural norms, thinking that your cultural practices and customs are the correct standards that others should follow. As an example, some cultures, looking someone directly in the eye might mean that you're respecting them and that there's honesty within your relationship. However, in another culture, it can be interpreted as rude and even confrontational. Socioeconomic bias. Socioeconomic bias is making an assumption about a person's socioeconomic status based on what you see or know of a person's experience or education, their postcode, their appearance or their accent, or their social class, and then using these assumptions to influence your practice. As an example, as a health professional, you may assume that individuals from lower income backgrounds are less motivated to manage their health, This could lead to less support or fewer treatment options being offered. Or it might be that people from deprived areas might be perceived as exaggerating symptoms or seeking drugs, resulting in undertreatment of pain. Gender bias. This could be favouritism towards or prejudice against a particular gender, making assumptions about roles and responsibilities. As an example, this could be dismissing domestic abuse claims from a male victim. So within bias, we should also consider intersectionality. So intersectionality is when multiple forms of inequality or oppression of a social group, so say gender, race, ethnicity or disability, interconnect. They're then compounded to produce outcomes and create different modes of discrimination or disadvantage. Okay, so what is the impact of unconscious bias in our work? So many people may not realise that they hold unconscious biases, which makes it harder to identify and address. There can be resistance to changing behaviours or questioning long-standing beliefs. Unconscious biases can be built into an organisation's systems and their structures and processes. And an organisation's culture can subtly reinforce certain biases through traditions and language or established practices. It can be difficult to challenge and change those norms as individuals may fear confronting bias due to perceived negative repercussions. This can discourage open and honest discussion about bias in the workplace. Confronting bias often requires an uncomfortable conversation. Stereotypes can become deeply embedded in both societal and organisational thinking. And overcoming unconscious bias can be difficult, especially when this is influenced and reinforced by media, historical prejudices and cultural norms. Limited exposure to different perspectives and experiences can also contribute to the persistence of bias. And the use of biased language in communication can reinforce stereotypes and help sustain the unconscious bias. So when we think about unconscious bias in adult safeguarding, the decisions we make can be significantly affected. It can lead to misjudging the risk levels based on stereotypes rather than evidence. You might overlook the signs of abuse or neglect in certain groups, certain communities. You might make assumptions about the capacity or credibility of the adults based on their background, and making safeguarding decisions that may not be in the best interest of the person and not making safeguarding personal. So what can we as health and social care professionals do to mitigate these biases? Well, you can question your gut reactions. Take time to build rapport with people. Use your supervisions and your peer discussions to reflect on your practice and explore your assumptions. You can engage in regular training on biases. Bias awareness isn't a one-off training, it's not just this guide. Be curious. Learn from people with different lived experiences to your own. Ask questions. Ask your colleagues. Ask clients and customers and patients. Explore different communities. Use multidisciplinary approaches to gather diverse perspectives. Use structured decision-making tools to ensure consistency. Encourage an inclusive environment, making safeguarding personal, where all voices are heard and valued. Maybe introduce different initiatives in your workplace aimed at addressing unconscious bias, such as having difficult conversations. And then ask yourself, am I seeing the whole person, or is this a stereotype? Thank you. If you'd like a copy of this slide, please visit our website at the West of Berkshire Adults Safeguarding Board. Thank you.